today. I know it's very difficult to get everybody together.
Yes.
As evidenced by the emails flying back and forth, but we truly appreciate that. We've got a novel idea that we would like to talk to you about and see if we can get some collaboration going. First of all, I just wanted to go through and give you an idea of who we are. J&N International Medical Corporation. We're in Omaha, Nebraska. Let's see, I should be able to just, yes, there we go. We're a small biopharmaceutical company. Started in 1998. Dr. Jeeri Reddy started the company. We're basically looking at our bread and butter products is meningitis vaccine. We've got a conjugate vaccine that we're going through the FDA gauntlet with through the clinical trials and getting that to
Is this for
market.
meningococcal meningitis? What kind of meningitis?
Yes, bacterial, yeah, and it's quadrivalent, ACYW.
Okay.
We've got some, a couple of good serial groups that Dr. Ray spent a lot of time in Africa, sub-Saharan meningitis belt, and we've got some very unique serial groups that we're using that seem to have a lot better immunogenic activity than some of the other vaccines on the market.
This is Dr. Pat Davis, one of the other stroke attendees.
Hi, Chuck Hankins, nice to meet you.
Glad to meet you. Hello, on the side of the guy. Nice to meet you.
Oh, doctor.
So, the products that we're working on, we've got the meningococcal meningitis vaccine. After Sanofi and Novartis, we're the third one that's bringing this to market. Some of the other things we're working on are some of the cure unknown neurological diseases. And that's what brings us here today, especially with the rapid diagnostic here for the stroke. And what we're working on is the same technology with Alzheimer's, Parkinson's, and some of the other things. And we do have a patent filed for this technology. We try and get out into the global community with some of the health initiatives. Dr. Reddy's very active in that, as you can see, in trying to get our name out and to help with especially the meningitis. We actually have a building and facility. It's two buildings. Actually, we've got an R&D QC side, and then we've also got a manufacturing side. This is BioCore. If you've ever heard, the old BioCore facility in Omaha, Nebraska was purchased by Pfizer back in the early 2000s. They came in, basically took the technology, moved it elsewhere. But in the meantime, they had built a beautiful top-shelf facility for vaccine manufacturing. CGMP, EU, I mean, it's just top shelf, the whole thing. And Dr. Reddy came in and was able to get that for the vaccine manufacturing. So we definitely have the facilities here for what we're looking at doing with the vaccines. To get into what we're discussing, Dr. Reddy's also got a lot of businesses and partners throughout the world. Sub-Saharan Africa, some of the offices that we have, is it Ivory Coast?
Yes.
Yes, and as well as working in some of the other continents. But to get into what we're here for today is we're talking about novel rapid diagnostics specifically for stroke, and then we'll look at an extension of that for stroke therapy that we're looking at down the road as well. Many of the things that I'm sure you're well aware of is how prevalent stroke is. The new AHA numbers that came out said almost 800,000 people suffered a stroke last year, 77% recurrent. A stroke basically every 40 seconds with a serious death every 4 minutes. The financial impact of that in Europe, 140 billion euros, about $74 billion for stroke. And this is not only the stroke, this is all the stroke-related costs, which not only is the immediate hospitalization, but the problem with all the rehabilitation taking so long. That's where a lot of these costs come from. TIA is what we're really looking at in ischemic stroke as opposed to hemorrhagic stroke. And again, you're well familiar with the biological and physiological parts of the stroke here, but ischemic stroke makes up 88% of the strokes that come in through the door, and this is what we're really targeting with our rapid diagnostic. What we're working on is trying to accentuate the current diagnosis. What we're seeing and what you see is that somebody that is suffering a stroke, by the time they finally accept the symptoms and go get help, and by the time the diagnosis is made, much of the damage is already done as far as the brain tissue is concerned. So what we see is that by the time the patient comes in, you've assessed their symptoms, you've ordered and gotten all of the testing that needs to be done, you've confirmed that there's actually been a stroke or there is a stroke occurring, you're starting to do therapy, much of the damage is already done. We've also seen where the TPA treatment for doing the clot buster type treatment really only happens in a lot of the urban hospitals where there's a stroke team that's available. Many of these strokes, if you look at the demographics, happen down in the southeast in rural communities where they don't have that type of hospital or health care available to them. So consequently, by the time they do get the health care that they need, the stroke damage has been done. And again, this is a paper that was done. In fact, I think you're actually quoted in there, Dr.
It
Adams.
probably is true. Yeah. Whether my quote is correct is another story.
So really, again, what we're looking for is timing is critical. If we can help accentuate, supplement that diagnostic portion of an ischemic stroke, then we can see the therapy happening much quicker, and thus the outcome for the patient being much better for their prognosis. So we get into that, what we're looking at is the mechanism. When we see a stroke coming in right now, as I said, normally the stroke team or vascular neurologist isn't available on many of these. So again, we're talking about the same thing. By then, 70% of the damage to the brain cells has occurred. I'm getting a little ahead of myself here. Consequently, the ASA has looked at a guideline for trying to evaluate and get a decision on treatment within the first 60 minutes. When you're looking at onset of symptomology, transport, getting a person to the hospital, the 60 minutes is really a lofty goal and very difficult in most circumstances. So what we're looking at is trying to diagnose that ischemic stroke much quicker, possibly even in transport if you've got the right type of rapid diagnostic. The other problem that you see is that normally now they're looking at trying to implement, I think I was reading it's the one of the stroke scales. It wasn't the NIH one. I think it's the Melbourne stroke scale. They were looking at trying to implement within the ER people that are actually the paramedics, so that they can help to try and diagnose or assess the condition of the patient before they come to the hospital. What we're looking at is trying to get in that first line of diagnosis with the paramedics to bring in more information once they get to the hospital to help with that diagnosis. And the way we're looking at doing that is trying to look at some of the markers that are present in a person who's suffering for the ischemic stroke. So here we're talking about obviously the blockages. There's many things happening in the body. It's not just a thrombolytic type of activity or a blood clot that's happening. There are a lot of biological markers that are also being present in the body, and these are going back and forth across the BBB. What we're doing is we're trying to identify these, and these are the ones that we're identifying with the NAMDA receptors that is resulting in the cytotoxicity and the neuronal damage. So the mechanism for that, and if I was really smart, I would turn this over to Dr. Reddy for the actual mechanism. Again, you're probably very familiar with the calcium influx with the NAMDA receptors and how this whole mechanism works. What we're highlighting and looking at is the actual cleavage of these subunits. That's what Dr. Reddy and Dr. Bedai have been spending their time on. And this is the mechanism of the marker that we're actually looking at, identifying and utilizing for the rapid diagnostic. Timeline. Many times, and I'm probably one of the guilty ones, they always say guys that are in middle age or so ignore symptoms. So you've got TIAs, you've got people having mini strokes. I think the definitions of mini stroke is less than an hour, up to an hour. Many of these can last a minute or less than 5 minutes. If somebody suffers this and the symptoms are gone within a couple minutes, they're probably going to just, oh, I'm okay now, don't worry about it, and they don't go in and get treatment. This is a warning sign. This is a warning sign that they may suffer the ischemic stroke. So what we're looking at is a rapid diagnostic that not can only be used here, but also for someone who has that question and comes in. And not being on the medical side, I would imagine if someone is smart enough to come in after having a mini stroke, but the symptomology is gone, the cause is gone by the time they get to the hospital, how difficult is it to actually diagnose that they suffered a mini stroke or a TIA? I'm looking for your input there. It's very difficult, isn't it?
It can be, yes.
Yes. So, and the other thing is that many of those symptomologies can be confused with other problems that they may be having, which could be difficult to diagnose as well.
What about seizures? That's one of the main differential diagnoses. Wouldn't the NMDA subunit also be increased in that situation?
And that's actually when we get further in here, what we see is that you're ahead of me. The NAMDA subunits, what we're seeing is we're seeing the same mechanism, not only for the stroke with the markers, but there are other markers that can be associated with other type of neural type of problems. And that's exactly what you're getting at. So we see, right now we're looking at just the stroke and ischemic stroke because it's well known which markers signify an ischemic stroke. What we're also looking at is utilizing the same technologies for possibly Alzheimer's, some of these other neurological
But I'm
diseases.
saying, what happens sometimes, the most common reason that someone's misdiagnosed as a
Mhm.
stroke is they had a seizure and we just see them in the
Yes,
central
Yes.
order.
what we
yes.
are finding here is the autoantibodies for the NAMDA receptors. The mechanism which we have been reading a lot of literature, that some of the TPA and some of the serine proteases that cleaves the NAMDA receptors well before the TAA comes. But they develop the autoantibodies into the system actually.
Mhm.
Our concept is we wanted to find out those autoantibodies are formed or not. Based on that, we want to diagnose it with literacy, whether this person is going into a stroke or TAA. That's what our concept
So
is.
the autoantibodies happen before they develop the symptoms?
Before the, yes, that's correct, ma'am. Before the symptoms,
That's what we believe.
that's what we believe.
When the BBB
Not only
compromises.
that this has been proved in one very excellent paper has been published by the Russian group. They already have a ELISA test kits for this,
Mhm.
and they have done a very big study in Russia about using about 400 patients with ambulance type of treatment. They found the autoantibodies for the NR2A of NMDA.
This is actually what we're showing here.
Yes.
These are the NR2A and B autoantibodies, and what you've got is the TIA and ischemic stroke patient with your basal,
C is
titer.
controller.
and you've got hemorrhagic stroke, and you're seeing that that's not present. These particular autoantibodies, and I think this was a couple of other. This is your control. The other interesting thing is that you see is that they were looking at the correlation between the titer and the NIHSS score. So actually, as the titer went up, you could see the severity of the stroke and the damage associated with that stroke being directly
I guess that's not
correlated.
surprising if you think the larger the volume is associated
Exactly.
with the severity of the stroke.
Okay.
And so
Yeah.
more, theoretically, more receptors are going to be affected.
Exactly. I mean, it's just it's a cascade that's happening, and it just geometrically expands as the
I'm still a
severity
little
goes up.
confused as to how this could be used for the TIAs or for the people with warning symptoms. Right now, one thing is, if this is, you have data like this which are impressive,
Yes.
but how will this supplement the neurologic exam? Because those patients with an NIH stroke scale of 15, there's not going to be much doubt about it being a stroke.
Right.
And they will have imaging findings, MR or CT. So how would this help us in that niche, in improving diagnostic accuracy or improving treatment? Because you've already mentioned time is brain,
Yes.
and this has to be turned around very quickly if it's going to be. There's several things that I'm going kind of wandering around, but I'm still not quite sure how you guys foresee this fitting into improving diagnosis.
In two ways. The first one is with the TIA or a mini stroke, is that being able to show with the biomarkers and the serological markers that is truly what has happened, based on
Okay.
the definitive markers for the TIA.
All right.
So it's not, maybe seizure or some other problem.
Do we
You
have,
can
have
actually
you already
so-
differentiated those?
Yes.
So what we are doing here is we are studying the underlying mechanism of the NAMDA receptor cleavage
Okay.
by serine proteases. So when the BBB is compromised, which there is no other test or technique that will show what's going on in the brain environment. Unless we study these biomarkers, the cleavage of the NAMDA receptors.
Okay.
So that's underlying mechanism during the TIA phase itself. So slowly it increases the cleavage of the NAMDA receptors. So if we take advantage of those fragments that are released into the circulatory system after cleavage, we can detect what's going on. If the TIA is progressing, if it is progressing, then it may lead to the ischemic stroke. So if we diagnose in the TIA phase, then we can, there's a...
Well, one of the
We
things-
see this
one
as
of
a
the-
supplemental diagnostic
One of the
tool.
things that I think, there's not much difference between Nebraska and Iowa, is there? Okay, except that you cross the river,
Right.
right? Western Nebraska, eastern Iowa and western Nebraska look an awful lot alike, right? Same hills, same cornfields, etc. it's the same thing is true with ischemic stroke and TIA. This is a continuum. These are not
Yeah.
Right.
two different diseases. This is
Right.
all the same disease.
As of today, but if we develop this diagnostic kit, it may give us opportunity to differentiate way ahead. I
Right, you see, that's what
many days
Severity.
I'm still. I think I'm having a hard time quite understanding how this is going to work. But that's fine. That's what you're
Severity,
here to.
severity would be the river. I mean, the TIA is less severe, less
All right.
debilitating.
Okay. Okay. That's true.
Yeah.
So that we have the Missouri River to separate them, but it's still, it is a continuum. It's the same
Right.
farmland. All right.
With the same
All right.
same underlying mechanism.
And so, and same underlying mechanism. And if this is released, we'll say with the TIA, you have an ischemic injury. There are some of these antibodies produced. There's breakdown and cleavage of the NMDA receptors, right? This is going to be there for a transient phenomenon.
Right.
All right. More the duration of the TIA may affect the levels, I guess.
Yes.
The severity of the TIA will affect the levels, I would
Right.
guess. But it would depend on how useful this is going to be. If, we'll say, a patient has a TIA on Saturday and now arrives on Wednesday, all right, are these levels going to have disappeared and not, do they persist, etc.? These are all questions
Right.
that are kind of coming in my mind as a clinician as to how this will work. Then Dr. Davis's point is that anything that disrupts the blood-brain barrier, your meningococcal meningitis disrupts the blood-brain barrier. Seizures disrupt the blood-brain barrier. Stroke disrupts the blood-brain barrier. A lot of things will do this, and there's going to be specific. And now the stuff with intracerebral hemorrhage I find interesting because that kind of suggests there may be some more ischemic phenomenon, but actually part of what epilepsy can be ischemia. They can have some local ischemia because of the metabolic demands that are raised at the time of the seizure. So how this would firm up the diagnosis of TIA? Somebody had a spell on Saturday, shows up on Wednesday. We do this blood test. That's the scenario that you're going to have to convince the clinician how it's going to help.
Okay. Now that honestly, with the markers are not persistent for over 24 hours.
All right.
So that's a limitation.
All right.
The niche that we're looking at for this diagnostic is to supplement the current diagnosis methodologies that are in place. The stroke scale, the assessment, if they're doing some type of CAT scan or MRI, or whatever they're looking at, but this is a serological marker to accentuate or supplement that diagnostic process so that possibly they can implement treatment sooner.
Okay.
But initially you were talking about transport. If this,
Yes.
if there was hypothetically a serological test that with 100%
You're talking about a thing
sensitivity,
that's just like a pregnancy kit. Drop of blood, 5 minutes at the most.
If you could rule out hemorrhage
If
in
you
the
could-
ambulance, that would be tremendously useful.
right? Because then you could treat
Yes,
people.
yes.
in-
If this,
right.
if this was a substitute for a CT, that'd be very helpful. If this, in an emergency department where we have a CT that's negative with ischemic stroke, most of them are, and this was positive, it would eliminate the issue of something else.
Right.
If it was really specific,
If it's
you have to have a
It's very
high degree of
specific.
specificity. Can't be a high rate of false positives. All right?
Particularly for hemorrhage, it needs to be very specific for that. That could really expedite treatment.
Then the other
But
thing,
differentiating TIA from ischemic stroke, I don't think.
I don't think
I don't think the
and we're not
clinicians need
looking
an
at
additional
differentiating
treatment.
between
Yeah.
the two. We see the both of them as being, a problem. It's just a level of severity.
Or even
But we
perfecting the
actually-
diagnosis is not
We
necessary.
could actually diagnose the TIA or stroke as opposed to other things that could be potentially mixed up with that because of
See, if you
symptomology.
could eliminate it being
But
a
expedite
seizure,
that
would help.
diagnostic
so.
process.
If you had somebody that came in an emergency department, we're down there seeing them, and we get the CT. They all get CT. That's part of the national guidelines. The things that Enrique said in the ambulance, where we could eliminate hemorrhage early, so that we could, with enough degree of confidence in this test, that we could say, okay, we could treat them with TPA in the ambulance. That's number one. Number two is in the emergency department with a CT that is negative. Most ischemic stroke CTs are. But we still have enough that we can say this is for sure ischemic stroke. That's number two. Number three is if you have a patient with an ischemic stroke, if this would provide additional guidance or information about prognosis. So this, because there is a lot of interest in biomarkers for prognosis of patients with stroke. If this, because we've looked at varieties of things, most of which have not worked, all right? But if this would be an independent predictor of outcome, more than the United Stroke Scale, more than the general patient's condition, then that would be extraordinarily useful thing.
And that would be an extension of where we're going with the rapid diagnostic. The rapid diagnostic in the beginning would be a qualitative test. It's going to tell you whether or not you've got these elevated autoantibodies for those specific NAMDAR receptors.
What does the curve look like over time, like troponins? Does it go up and then peak and
It
then
does.
come down?
It does. It goes up within the first couple hours.
When it goes to ischemic stroke, really, if the person gets the stroke, there will be no antibodies.
I've actually,
The antibodies will be they will drop
after 24 hours.
after 24 hours.
So-
But it goes to a peak.
It does.
and
I've
drops
actually
off.
got that graph, and it's on
Yeah.
a different file, and I can show that to you when we're.
But so, for example,
I had a
if the
slide
stroke
that he put
happens
in.
at noon,
Yes.
how soon are the antibodies there?
Almost immediately.
All right. And when do they get, and we'll say it's a bad stroke, it's a score of 20 on the United Stroke Scale. When do they peak out?
1 to 3 hours.
So like 1 to 3 o'clock, and then they start going down.
Yes, and then
And then it's gone by
Yeah.
24.
it'll be
Yes.
basal by 24 to 30, 32
But
hours.
The next slide you might show.
I only have the one slide here. I was going to put it in, and I know
So
we're
like
for
troponins,
time.
would you do it serially to see where it peaked, or it would depend where on the curve you were if you were going to use it prognostically? If you did it
Yes.
at half an hour, it would
And that's where I was
be
getting
3
at, is you
hours.
can take the same technology and utilize it in a reader-type system so that you get a quantitative relationship on the titer. So again, you can look at this correlation with the severity and the titer of the autoantibodies and give you an idea of just what stage they're in as far as the cytotoxicity that's happening. And that's just a logical extension of where we're going with this technology. The thing that we're not looking at right now with the reader is because we're looking at time as brain.
Okay.
And when you send a sample down to the lab and they have to read it on an instrument and wait for it to go through the instrument, that timing is critical. So we were looking at if we can do a rapid diagnostic to accelerate that that process, then the treatment, because if you can get the treatment sooner, then the prognosis is going to be better.
Yes,
And
that's
that's really what we were trying to aim at with the rapid diagnostic. So initially we're looking at qualitative, but the valuable thing with talking with people that actually do this for a living and the clinicians is understanding what your need is.
So in those graphs there, is that volume and a United Stroke Scale later as opposed to simultaneously?
They were done simultaneously.
So do you see a change in the United Stroke Scale when you see the change in antibodies?
No, because the antibody peaks at a certain titer, which is again going to be directly correlated to how much excitotoxicity happened, which again is severity of the stroke. And by then the damage is done, and then you've got your
In other words,
debilitated.
does it precede the neurological consequences?
Yes, yes. So it could be an indicator of potential damage.
Well, that's the
It
prognostic.
could be also used to
Yeah.
exclude treatment
Yeah,
in persons
yes.
that you suspect functional symptoms, and you're not willing to expose them to treatment.
Yes,
If
yes.
it had a negative predictive value. So it could be used for more applications than treating, actually for not treating people.
Would save a lot
Yes.
of money if you didn't have to do MRIs on all those people.
Yes. Time and
Yes.
money.
I don't
Yes.
say that MRI should not be done, but it is better than CT.
No, I'm
Scan.
saying if you got a really specific test
Yeah,
that said
if you don't
this
have to do
is
the imaging
not
at all.
a
Yes,
stroke,
yes,
you may not have to do the imaging, which is time
that's
consuming and
correct.
Yes.
That's
expensive.
correct.
Because we see lots of people with unusual symptoms and we
Yes.
end up having to do the MR.
And sometimes they're more useful for that than actually for diagnosis. For
Yeah,
example, the
sure,
D-dimer
sure.
excludes.
So, for example, the patient with functional hemiparesis that comes in and we don't know if it's a stroke or not, and you end up having to treat them because you're not sure what it is.
Right, and scan them.
Mm-hmm.
That's what, $6,000 there, you could say.
Mm-hmm.
No, I mean, you bring up some interesting points because, I mean, we kind of look at it from a scientific research standpoint, and it's very valuable to get the feedback from the people that would actually utilize it in the circumstance and to understand what its value could be. And,
So now-
I keep hitting on that, I'm sorry, there we
So
go.
now how far along are you on this?
We are actually getting, Dr. Reddy, I was just going to get in these next couple slides. He has a lot of experience with rapid diagnostics already that he's done out in the field. And we're utilizing the same technology, and they're developing this. We're on about a 3-month timeline.
Actually, biomarkers are all completed. Dr.
Yes.
Sai has,
Yeah, we are in the process of producing them. The cloning part is done, and then we expressed. Now we're developing methods for purifying those.
They have some immunoblots they have done with rabbit, anti-rabbit antibodies, but we are looking for serum also for human serum. How specific it is.
So we are in the
To
process of
optimize
screening
this,
them.
we require a human serum, human stroke patients and normal serum to optimize completely, not to have any false positives in it. We have to do a lot of work here. But
So
the
how far,
biomarkers-
you're pretty far, you're just at the beginning of this, is that right? How far along are you on testing this, these biomarkers?
That's where we're at
Not
right
too
now.
far.
Yeah.
actually.
We're kind of
The
at,
peptides are made, what we need to do is start to do the testing.
all right,
And we need the positive serum samples to be able to do that.
all right, so you need serum samples drawn from patients
Yeah.
Yes.
at different time epochs
Yes.
from onset of stroke to find out how far along, A, if it's positive or not,
Yeah.
B, if it is, how high the levels are, to confirm or refute the Russian study, all right?
And you need some stroke
Yeah.
mimics.
And you need some stroke mimics to see if they're negative.
Mhm.
And you
And
need
some TIA,
and okay.
not only strokes.
But you know,
Everybody-
alternative diagnosis. It would be very important to have some patients with seizures.
Mhm.
Important to have
Yeah, to rule out.
a hypoglycemic patients or
Mhm.
metabolic. It's the differential.
And you're bringing up the things that we would have to incorporate into a clinical study for a
Actually,
510K.
whatever Dr. Adams says is very important.
No, and that's what I'm saying. He's
What
bringing
a-
up some excellent
we have
points
to
that we
have
need
a-
to
Number of negative samples
Yep.
to prove this is
You have to
definitive
find
and
the
specific.
specificity and
Exactly.
sensitivity
Yep.
of this test. So that what its positive and negative predictive values are. Am I doing right? Are those the right terms, gurus over here on the left?
Yes,
To
it
rule
is.
out other
Yes, it is.
conditions which have similar clinical symptoms. That's what.
And you also would be very helpful to do some reproducibility so that the same samples are come out with the same results, etc.
You're bringing up all the points that we have to do in design control for the submission of the 510K to the FDA.
So
Our clinical studies need to incorporate all the things that you just talked about
Yeah.
and answer those questions.
Are you going to test it in different clinical settings like emergency rooms, transport, etc., or how do you envision doing that?
What we're hoping to be able to do is to set up multi-site type of study. Hopefully U of I would be part of that. And then as patients come in, be able to utilize some of the blood sample to do on the diagnostic on the side, and then coordinate that or correlate that to the actual patient outcome, so that we can see how well of a predictor it is, and the existing or established diagnostic tools, what that conclusion is, and then we can show the correlation.
Now, I'm sure you thought about that in the design, but some of those patients are going to be treated with TPA, right?
Yes.
And based on a presumed diagnosis of stroke, and then sometimes we're going to be totally successful and the symptoms are going to disappear. So what are you going to have as a truth for the control of the final diagnosis in that patient, where you did a rapid serological test, was treated with TPA, and the stroke disappeared? How are you going to know if we were correct, or that person had something else, a mimic that also may have improved?
I'm sorry, could you ask that
bring up a
question?
scenario?
No, when
You want me to say it again?
Yeah.
So
So-
somebody comes in, you draw the blood sample, you give them TPA, right, Enrique? And
Right.
then what happens? And then they get better,
And their MR is negative.
and their MR is negative.
Because you treated it successfully, right? What are you going to use
Or
to
did
say
you
the
treat it
sensitivity
better?
and specificity of that test? What is going to be your truth? If the truth was based on a presumed diagnosis that was treated and you don't have objective information?
actually
Your
the
diagnosis
TPA
is not
is a
definitive.
problem here for this test actually.
Yeah.
The TPA, what happens, it crosses the blood-brain barrier and it cleaves the NMDA. And I don't know how fast these antibodies comes, but our test will give a positive result there.
Just if they got
Yeah.
If-
So,
you have
so,
to
if the
draw it
sample's
before
taken
the-
after
so you have to draw it before TPA.
Yes.
Yes.
All right.
Before TPA, we have to drop it. TPA, it goes, it will cross immediately. Of course, it clears the blood clot, but we will have a positive result.
Okay.
Are there cross antibodies with other things, like with TPA? Some people have antibodies to TPA itself.
No, it doesn't interfere with
Okay.
TPA.
Okay, so they're not okay. So the issue would be this would have to be drawn when they arrive in the emergency department
That's
Or in
Yeah.
the ambulance.
or in the ambulance
Yes.
before they get any definitive treatment. That's the only way you're going to determine
Right.
how these samples. Then you're going to have, and then the Lyra scenario, which is somebody that is misdiagnosed as a stroke and turns out to be functional. Well, that becomes noise in the system. Is there any way you can handle that, Chris? If it turns out to be a false positive clinical diagnosis, we treat somebody, we do the blood work. We'll say, I'll give the example. It is negative, but we don't know. That may be the correct down the road, but it is negative because the patient was functional, but we treated them as a stroke, and so we cannot disprove the diagnosis of stroke because everything is clear.
It's an issue with the gold standard. What are you
Yeah,
using
right,
as a
right,
gold
that's
standard of diagnosis?
Yeah.
Especially in those patients that you clear the stroke
That,
and then the MRI.
though that will happen, I guess you just have to. The
Doesn't happen all
statisticians,
that often.
no, the statisticians are going to have to come up with a way to
Yes.
clean up after us.
There's no way to really,
There's no way.
there's no way to clean that up. If
All
you
right.
don't know truth, you can't.
All right.
Sensitivity, specificity are based on.
True.
A gold standard.
Right.
And
so-
sometimes we don't know, so even our clinical judgment isn't.
Yeah.
But
gonna
in
be
a way,
accurate
that's a
enough.
positive outcome.
Another thing is
I
very
suppose.
important with NMD and
And
symptoms
did you care?
that can be detected.
Well, but we're testing a
What-
diagnostic
I would
tool, not
care.
outcomes, right?
I would
NMD and
care
syphilis.
knowing
Oh,
whether this
okay,
test
okay.
predicted
That's
that
really
you were
rare.
functional.
Really?
And so I
Okay,
didn't
so
give you
your
TBA.
company will not succeed.
Yes.
Go with that one. All right.
The nice thing
Because
you
if I
bring up
miss the
there,
opportunity to
It's
teach
very
you
rare.
because
That's- You won't be
That's
Syphilis
able
is
to.
okay.
Okay.
if
All
this-
right.
That would be bad
These
news.
other
if
conditions.
the test comes up
Parkinson's
negative, there shouldn't be the
might be-
circulating
okay.
autoantibodies above the basal, which means they should remain functional as far as excitotoxicity or neurological damage is concerned, no matter what
Right,
the
but we've got to
mechanism
prove
is.
that that's correct, and that may
Yeah.
be difficult.
So you bring up that
Especially if
there's
they get
a
TBA.
gold standard or reference, if there one
Yeah,
that existed for diagnosis, that's what you'd be using
You would have
for
to.
diagnosis.
If
Right.
TPA affects this, which you guys made very clear that it does,
Yeah.
then it has to be pre-TPA treatment. And then you have to, in the baseline for the stroke, quantify for the severity of stroke, just for the severity of stroke as far as your antibodies, the interval from onset of stroke until the sample is drawn. Anything else clinically? Jim? Chris? Those would be the two. Age maybe, because age is such a, do antibodies different in young people with stroke and old people with stroke?
There's a
Same sort of-
possibility. It's a individual dependent.
Okay.
If the person's immune
Needs a
response
test.
is stronger, then
Are there other biomarkers that change that you can measure? MMPs or anything?
no, we are focusing only on these
no,
fragments.
but-
No, I know, but as a measure of change of the
Yeah, it's,
stroke.
it's used, because some of these are being used, some of these other things. Pat, you've gone over these
Yeah,
biomarkers.
there isn't a really good one that,
Yeah.
like, we need a troponin for stroke.
Yeah.
We don't have a troponin.
Right.
Okay.
There isn't a gold standard like that either.
Yeah.
Anything close, nothing close. You went over all this with us,
Yeah, I've just
Fran.
been through this literature and there isn't a good
It's a
candidate.
morass, isn't it?
Yeah.
Okay. I was just trying to get another, what we're trying to do is get something to compare this to see we're running the
Because
same one.
MR isn't going to be perfect if they're TIA,
Mhm.
or they're functional, the MR is going to be normal.
There is
Procedure.
nothing like a rapid test for this.
Seizure
There
may
are
or may not be.
time delayed test kits or ELISA. That's why they go for ELISA. By the time they can do MRI, the ELISA take 3-4 hours. That's why.
No, a test that takes 3 or 4 hours
Yeah.
will not be helpful in
Yeah,
this.
you
Yeah.
miss
It
the
has to be,
window.
it has to be something
Minutes.
that minutes.
Yeah.
All right.
Right.
So, but isn't, the issue with the TPA was, there's almost at least two steps here, right? One's the sensitivity and specificity of the test itself.
Yes.
But then I would imagine the final, at least one of the major objectives, which gets kind of at that point, is does using the rapid diagnostic test in practice lead to better outcomes?
A better predictive value.
Yeah.
Very predictable.
It's really going to be a prognostic
No,
value.
outcome.
No,
Outcomes?
but also, I mean, what you're using is a diagnosis to
Oh, all right.
tailor who to treat, who
All right,
gets to
okay,
treat.
okay,
It
all
helps
right.
with the
That's right.
treatment.
All right, so we have 3 different.
Serological